It really is an honor and a privilege to be here. So tonight, Jennifer and I together will speak about stroke and particularly addressing the issue of neglect. Often misunderstood, not clearly recognized problem. And that's in part why we're looking at this research and why Jennifer specifically is addressing the condition of neglect. So I'll let her certainly speak to that in much more detail. I'm going to begin by just giving a bit of an overview of stroke, staying relatively basic and going from just what is a stroke through to the arterial issues, some of the problems, what causes a stroke, and then into the neuropsychological consequences of stroke, at which point then I'll turn it over to Jennifer. Often lecturing at UBC, I teach a class there in neuroscience, and I say to my friends that the one thing that never changes, that the students always stay the same age and I just get older, and so the difference becomes much greater. So I'm really appreciative of this audience where we're much closer in age. So thank you for that. I hope out of this that you will have an appreciation of what stroke is, what causes stroke. You'll have an understanding of some of the statistics related to stroke and the disability issues, appreciate the neuropsychological consequences, and then be able to explain and understand and talk to others about what neglect really is, how it manifests itself, and what we're trying to do from a research end of things. What is a stroke? Stroke in general, or in very brief, is an interruption in blood flow. So you can have that interruption in blood flow in a number of different ways, and we'll look at some of the specifics in a minute. The primary issue, though, is what happens when you interrupt that flow of blood to the brain. In essence, we have challenges with oxygen, glucose, and the metabolites. So the brain needs to be fed with oxygen, glucose, metabolites, nutrients. If it doesn't have that supply, it tends to have deleterious consequences and, in essence, cell death. And so we'll talk about that. The brain is an organ that doesn't store glucose, doesn't store oxygen. Other organs in the body have some capacity to do that, so the brain doesn't. So it gives you an idea that when you shortchange it for even a very small period of time, you start to experience cell death or changes to the cells. Cell death can occur, in essence, in about a 3 to 5 minute window, so it's a very short amount of time. And the longer in time that you go without oxygen, you can certainly see those very negative consequences, and often irreversible, which we'll address as well. One of the things that you can think about in terms of loss of oxygen and nutrients to the brain, for anybody who's familiar with cardiac events, if you have somebody who has had a heart attack and they're down for a period of time and they've not had oxygen, so there's no CPR provided and so on, the longer in time that goes, the more likely you're going to end up with significant cellular death, and we see marked ramifications of that. So that gives you a bit of a picture of how fragile the brain is, how limited its ability to compensate for a loss of oxygen and glucose and nutrients. But that's in essence what happens when we have a stroke, and we'll see that we can interrupt that blood flow in different ways. So I just want to start here and give a bit of a perspective on the circulatory system in the brain. So there are 3 main arteries that feed the brain. There's an anterior cerebral artery, a middle cerebral artery, and a posterior cerebral artery. So as you look at that, you'll see that in the far left, you'll see the outside of the brain, or what we call a convexity. And that is typically fed for the anterior, moving towards the back of the brain, by the middle cerebral artery. If you look at the other picture up in the top corner, you'll see the inside half of the brain, and that is fed by the anterior cerebral artery. If you look at the back part of either of those 2 top slides, that tends to be fed more by the posterior cerebral artery. So 3 main arteries: the anterior, middle, and posterior cerebral artery. Within the arterial system, we have something called a circle of Willis, which is combined of those 3 particular arteries I just mentioned with 2 what we call communicating arteries, or they join those 3 together. So we have an anterior communicating artery which joins 2 anterior cerebral arteries, and we have a posterior communicating artery which joins the middle and the posterior cerebral artery. By having that particular circle of Willis, as it's called, it forms a circle, it can at times allow the brain to compensate for changes in blood flow because of perhaps some blockages or narrowing of arteries where the blood doesn't flow as it's supposed to. You can have some compensatory mechanism because you do have a contiguous circle. And I mentioned that because of that potential for that particular development in your brain to protect you to some extent from some of the aspects of stroke that would occur if that was not present. Now, if you look at the bottom one, you can see where that dotted ring is. That essentially is indicating where the circle of Willis lies, and it runs around that central area of the brain. So again, just to go over one more time, anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery. And those three arteries, and there are three on each side, one of each on each side of your brain, connected by the posterior and the anterior communicating arteries, form that circle of Willis and gives a very nice vascular picture in terms of managing blood flow to the brain. Now, there are obviously a number of deep penetrating arteries that will be collaterals off of those main arteries that help to feed the deep structures in the brain. So one way to look at this is that we have a wonderful setup in terms of the brain receiving blood flow. We also have many opportunities for blood flow to be interrupted and to have damage at various different aspects within the brain. So as you can have very cortical issues, so the outside surface of the brain, the cortical areas, to the deep subcortical inner structures of the brain. And by virtue of having damage to different areas in the brain, depending on which arterial distribution is affected, you will have different presentations in terms of the functional, first the damage and the functional outcome that you will appreciate as we talk about in terms of the neuropsychological consequences of stroke. That was all the positive side, showing the brain in its full form and working well. When we have that interruption or change to blood flow, we end up with what's called a stroke. And there are different subtypes, and we break them down into basically ischemic or hemorrhagic. Ischemic really refers to a narrowing or a complete blockage of an artery, which ultimately then restricts blood flow through to the brain. So you can have that through a plaque buildup. So it can be a very local buildup of plaque and blood products. Or you can have an embolic where it may be a clot or some material forming somewhere else, and then it moves through the bloodstream until it gets to a point where it can't go through any further, and you'll ultimately have a stroke at that point. If we go back to this diagram for a minute, what's also important is that we have something called watershed areas. And watershed areas refer to those points in the distribution of whether it be the anterior, middle, or posterior cerebral artery, where you come to the end point. And if you think about pressure flow, as you move further down the line, you're going to have less pressure. So if you have a blockage somewhere, your point of dysfunction, or where the stroke will manifest most highly, will be in those furthest areas away. And so that's where you sometimes tend to see the stroke occur, is at the confluence of the two arteries where their end points, their distal points, are coming to a union, except that the blood flow has been circumvented because of the distance from the source. One way to think about it is if you think about your garden hose and you have it running out, and it might be one of those ones with all the holes in them, so you've got that, I think they're a soaker hose. If you turn the tap on full blast, you'll probably get good pressure all the way to the end. But if you start to reduce the pressure, you'll start to see that the areas furthest away from the source, meaning your tap, will receive less flow. So that's where you get your brown lawn. So similarly speaking, that's where you'll end up getting more of that damage to the brain, is in those watershed areas. I had a really interesting neuroanatomy pathology prof present this to us, and he had gone to the Taj Mahal and taken pictures, and there's a fountain, for those of you who may have been there, it's a fountain that runs along from the palace outwards, and you can see that the pressure drops off in that fountain as it goes out towards the end. So very similarly, that's what can happen in stroke. And so those areas that are going to have the least amount of pressure during a stroke condition will suffer the most greatly in terms of tissue damage. Now, in terms of hemorrhagic stroke, this is a little bit different, and it really is a rupture to the arteries, and it will produce an outpouring of blood. And we can have either intracerebral, or I can refer to it as extracerebral, meaning either within the brain itself or in the outside part of the brain and between the linings of the brain. With an intracerebral hemorrhage, you can have, if you remember, there are deep penetrating vessels. There are also the vessels, the bigger ones. A rupture to that vessel, either and most often due to an aneurysm, and probably of a congenital nature. The aneurysm can weaken the walls of the artery, and ultimately blood will leak out or perhaps pour out in many respects, and the brain doesn't manage that very well. In a subarachnoid hemorrhage, this is a pouring out of blood between the linings on the brain. And there are three linings. There's the dura mater, which is a tough outer layer on the brain. Next layer is the arachnoid mater, which is sort of a spider web-like, and then the pia mater, which covers the brain itself, a very delicate lining. It's not uncommon to see a subarachnoid hemorrhage where the hemorrhage or the bleed is between the pia mater and the arachnoid mater, so it's between those two layers. While one might think, well, that may not be as bad because it's not in the brain per se, it's on the outside, it has the effect of producing significant pressure on the brain. And one of the things that the brain does not do well is manage pressure, because there's nowhere for it to go. The skull is a fixed entity, so it can't push the skull apart, and it ultimately pushes your brain down through the area between where the spinal cord and the brainstem come together, and that creates major issues in terms of life-sustaining capacity. In general, two types of strokes, ischemic and hemorrhagic. They have different courses in many respects, but they have the potential certainly to produce some fairly significant issues overall, certainly from a neuropsychological perspective and ultimately from a functional standpoint. So here's just a graphic demonstration of an ischemic type stroke, and you can see the buildup on the walls. Over time, that buildup will continue, and it can either severely restrict flow or it may block flow altogether. So, and as I mentioned, when you do that, you certainly run the risk of having a stroke if there isn't a way to have some compensatory component to it. Now, we do know that it's not uncommon to have what we call small vessel disease, where there may be some vascular issues happening very deep in the brain, and those issues may not present in a significant way initially until you have a number of those small vascular hits, or you have a much bigger stroke, and you start to see the cumulative effects of those multiple vascular aspects to your brain, those multiple strokes. This is a schematic of a hemorrhage where we see the vessel rupturing and the blood moving out into the brain. This will be what we'd consider an intracerebral hemorrhage, where it's actually in the brain itself where you're seeing that blood coming out. If there was a lining there and you could see the collection of blood between the lining, that would be the extra or subarachnoid hemorrhage. Generally speaking, we think of stroke as something that happens in people who are older, and typically in that age of 65, 70, and so on and such. And there's no denying that stroke will be more prevalent as we get older, but we can also say that stroke does happen in a younger population as well. And certainly if you see a stroke in a teenager or somebody who's moving into their early 20s, that may be due to what's called a congenital malformation. It's an arteriovenous malformation. So it's congenital in origin, and then it will rupture right in around that time. And so it has all the same manifestations as you might expect with the stroke that we talk about in adults, but in certainly a much younger person. And I'll also add that when I started at Kelowna General Hospital about 20-some years ago, I would suggest that our average age for stroke was in the area of probably 75, 80 on our unit, on our rehabilitation unit. Today, I would say it's come down considerably, and I would have no doubt if we ran the stats that it would probably be in the area of 60, 65-ish, and maybe even a bit lower. And it's not uncommon for us on our 30-bed unit to have anywhere 5 to 10 who are well under 60. It's an interesting change that we've seen over time. So while we would argue previously that stroke is a disease process of the elderly, and we still wouldn't disagree with that, it's certainly not exclusive of the younger population as well. So if you look at some of the incidence prevalence issues here, in Canada, we probably have somewhere in the area of 50 or more thousand strokes per year. Now, that's probably a bit of a conservative estimate because not every stroke is going to be reported. And there will be individuals, and we see this repeatedly on the unit, where they will, in retrospect, talk about some funny events that happened maybe a year previous that we could probably attribute to a stroke. Or we look at the CT and MRI scans, and we see that it's not just the acute event that's showing up, but they have some remote events, meaning that they'd had previous strokes but were unaware. And so it's probably fair to say that this is a conservative estimate. And if you go by the US statistics, they talk about 800,000, and we usually divide ours by 10, just by virtue of the nature of the population size. Typically, we could probably say 50 is conservative. We're probably moving much higher than that. And that's, we can look at this as being a fairly high number, and that's even taking into account that the incidence of stroke is coming down, certainly in first world countries, but that doesn't mean that they're certainly not present. Now, I can make a little bit of a joke, I think. I suspect that if Trump wins, so you know where I'm going. Now, the other part about this is that with stroke, about 25% or about a quarter of the strokes are recurrent. So they're with someone who's already had a stroke. So it's from this you can gather too that there is an increased risk after having a stroke of having another stroke. Now that's a very general statement because there are different reasons why people have stroke, but if we take it in its general context, your risk does increase. And I think we can think of that in a very logical way too, that if you have an ischemic stroke and you have narrowing of the arterial wall and you have buildup of plaque, you can be pretty certain that it's not just occurring in one spot. So the possibility of having multiple strokes certainly increases as you've had one and you move on. And in fact, recently just saw a patient who had a fairly significant stroke on the left side of her brain and presents more recently now with a stroke on the right side. So it's not uncommon at all to have recurrent strokes. Now, ischemic strokes are much, much more common. So about 85% are ischemic. 10% are the intracerebral hemorrhage, so the stroke within the brain, and about 5% or a very small percentage the subarachnoid type. So the vast majority of strokes will be of the ischemic nature. The perhaps more significant statistic that we see is that of the 400,000 Canadians that currently live with disability related to stroke and long term. So we're not talking about somebody who has a very, very good recovery and doesn't have much in terms of any functional change. It's individuals with the long-term problems. These are individuals who no longer can return to work, perhaps may not be able to live on their own, may need some supports in the home to be able to manage, unable to return to driving, and those are things that we'll talk about in a minute. But those are disability issues that are very prevalent for people after stroke. There's an expectation, too, that over the next 20 years, that number, of 400,000 will probably rise to about 700,000. So this is not something that's going away or is lessening right now. In part, you can attribute that to the fact that we're living longer, and so ultimately, as we said, age is a risk factor for developing a stroke. So on the one hand, we can say it's a function of age, and I think most of us would agree that we'd prefer to live longer. We increase our risk because with a lot of disease processes, whether it be Alzheimer's or Parkinson's or some of these other issues or stroke, we could eliminate it all if we all chose to die about 30, but I don't think that's our choice. On the rehab unit, we have, as I said, a 30-bed unit. And of those 30 beds, it's sort of a general neuro unit. So it takes complex neurological cases, of which might be stroke, traumatic brain injury, multiple sclerosis, sometimes dementia, as well as peripheral vascular disease, which is an arterial distribution problem, usually affecting the lower extremities more so. But of that group, I would probably suggest that 70 or so % of our patient population on the rehabilitation unit are stroke. So, and in part, that's because of the demographic for Kelowna too. So we know that that's likely going to happen. Conversely, when I was in Edmonton, we saw much more traumatic brain injuries. So the fact that we have that many strokes on the unit also reflects where we live. So as I said, a leading cause of disability, many people after stroke, the majority of people after a stroke will have moderate to severe impairment. So we don't typically get away with the mild. And it can run the range of physical issues, cognitive issues, and emotional. We're going to spend our time talking about the cognitive aspects, but just to cover physical in brief, some of you are probably very much aware of this, but the symptoms can include visual disturbance, sensory disturbances in terms of hearing, taste, and smell, so the basics in that respect, tactile sensation on one side of the body where you have a loss, the hemiplegias or loss of use of the upper or lower extremities. Now, one of the reasons why I spent a little bit of time talking about the anterior, middle, and posterior cerebral artery is that by having damage to one of those arteries, you can have a more classic presentation of physical issues depending on which artery actually the stroke involves. So if you have an anterior cerebral artery stroke, so more frontal, you tend to have a greater leg involvement. So the leg will be much more impaired than the arm. If you have a middle cerebral artery stroke, you will have much greater impairment of the arm or the upper extremity than the leg. So what you'll see presentation-wise is for somebody who's had a middle cerebral artery stroke, they tend to have a reasonable recovery of the lower extremity so they can walk. Their gait may be a bit abnormal, but they're able to walk. But you'll see often very marked, non-changing upper extremity function. So it will stay first initially quite flaccid, and then it will develop tone and become quite contracted and not very useful. So, and in discussion with a patient today, she was quite frustrated because the one side of her body is really not able to do anything. And she has good insight and good awareness, but really developing that frustration because she really is functional only on that one side. The emotional issues, which we won't delve into in any great detail, but they can range from depression, anxiety, to emotional lability where we're unable to control our emotions, to bouts of crying or laughing, which are uncontrollable, and happens usually at the most inopportune times where something may not be particularly enjoyable, but you start laughing. And it creates a lot of difficulties for those around, in part because they don't understand why it's happening, but it's not a controllable issue. But you can expect the whole range of emotional changes to happen following stroke. Some can be a direct consequence of the stroke. It can also be a secondary consequence. And as I mentioned with the lady I just mentioned, there's a very secondary component because she's recognizing the significant and profound change to her life by not being able to have function on one side of her body. So I'm going to move into the neuropsychology aspect here and what we're going to spend the rest of our time talking about tonight. And in this little schematic, just a bit of an idea of things that the brain does. And obviously we talk about thinking and memory and attention and concentration and visual spatial skills, the ability to problem solve and reason, and I'll address that in more detail. But one of the reasons why I like this slide is rather than piecemealing the brain so that we take it apart and talk about frontal lobes and parietal lobes and occipital and temporal as being specifically governing certain functions, I like to consider the brain as operating as a system. The brain works as a whole, and whether we're paying attention, whether we're solving a problem, whether we're going through the act of driving, there isn't one part of your brain that does that and the rest of the brain shuts off. So for anybody in here who still believes that old saying that we only use 10% of our brain, we need to get rid of that because it's absolutely not true. Your brain is involved in every activity that you do. Certain areas are involved in a greater or lesser degree, to a greater or lesser degree, but you don't shut off part of your brain while you're doing something else. And one of the points that I'll make here is that if we truly only use 10% of our brain and we had this 90% that was just waiting for I don't know what, we should then be able to have very good recovery because we got 90% that's just waiting to take over something. So haven't seen that happen yet. So important to not promote that kind of mythology. So in terms of neuropsychological consequences, talk about attention and concentration. So we talk about the ability to sustain attention, to keep that focus, to be able to selectively decide what you're going to attend to. And that's a really important variable, is if we're unable to select, we're bombarded by the myriad of information that comes in. And by virtue of that happening, you become overwhelmed because there isn't anybody who has an infinite capacity to attend. So following stroke, you can have that challenge where it's just too overwhelming. There's just too much going on, and we're unable to selectively decide what we need to attend to and what we're not wanting to attend to. The ability to divide your attention, to do this thing called multitasking, which I don't believe actually happens. We typically take several things and we do them sequentially. There are very few things we do where we do 2 or 3 things at the same time. Now, we might be able to listen to some kind of music and be reading a book, but the music usually has to be without words because it's hard to attend to both of those at the same time. So I'm not a proponent of the term multitasking. I'd rather think that we sequentially work through things. As a person who's had a stroke, you may find it's much more difficult to do that, and you may be relegated to doing one thing at a time, getting it done, and then moving on to the next task, rather than bouncing back and forth. Because as we talk about learning and memory, one of the facets that we need to have when we do that sequential processing is to be able to hold information in mind. And that's something we call working memory. And if you're not able to hold that information in mind while you go to do something else, you're basically starting over again. And that's one of the features that happens after stroke for many individuals, is that they're not able to hold that information any longer. And it's almost analogous to having, this group is old enough so I can talk about an Etch-a-Sketch. So an Etch-a-Sketch, as we all know, you draw on it and then you shake it and it goes away. And it's very much analogous to working memory for stroke or people who have damage in that area where working memory is impaired, that it's almost like the brain is being shaken a little bit, it disappears, and we can't remember what we were just doing. That's a very, very significant issue, and it does interfere with your ability to manage multiple things in a sequential manner. And you can only sort of also surmise that that's going to interfere with some even basic household tasks, never mind driving or working. Memory. We know that there are significant impacts for memory following stroke. And it can be, and it's typically for information that you're learning forward from the stroke, not remote memory. You'll have very good recall of information from the past. It's what you're doing day to day. And we often hear that comment that I can remember what I did 10 years ago. I can't remember what I had for breakfast today. So that's the kind of challenge that you're caught up in with that learning and memory component. Spatial and perceptual refers to the ability to appreciate where things are in space, to appreciate the distances between them, the relationships between them. Functionally, that translates into driving, translates into even imagining, let's say you're one of those people who likes to arrange the furniture in your home quite often, and then you don't tell your spouse and they come in and it's been rearranged and they trip. The point is that with good spatial perceptual abilities, you're able to imagine that in your head and develop those relationships so that you don't have to go to the process of changing all your furniture around only to find out you don't like it. So it's a very useful ability, and if that's altered, it changes things quite markedly. Processing speed is an easy one. How quickly we can keep up with things, how we can manage the information coming in. And for individuals who perhaps after stroke are unable to keep up with what's happening, they're always a step behind, and they're unable to stay in concert with what's happening. So in conversation, you may find that they just start to recede because they can't stay on task. They can't stay with what's happening. It also then affects your ability to pay attention, to learn and remember, and then obviously your problem-solving abilities are affected too. Which brings us to that aspect of executive or decision-making abilities. So your ability to problem solve, make decisions, to reason, to plan, to organize. All of those facets that in many ways we take for granted until they're no longer there for you. So it's not uncommon for those abilities to be affected. One of the areas that sometimes can manifest in that regard is interruption of mental flexibility, that ability to see different ways of doing things. And so we see people getting stuck on an idea, and they keep doing that despite the fact that it's not producing the solution that you want. But it's that ability to be flexible in your thinking. Language, not uncommon at all after stroke, and particularly left hemisphere strokes, you'll see potentially interruption in your ability to express yourself, but as well in your ability to comprehend and receive information. You'll see the terms Broca's aphasia, and that refers to the expressive component, and Wernicke's aphasia, which refers to the receptive. I'd prefer if people just use the terms receptive and expressive, and knowing that receptive is in the posterior aspects of the left hemisphere and the expressive in the anterior or forward aspects of the left hemisphere in general. So just a fact here. What's the percentage of individuals who have language, who are right-handed, who have language represented in the left side of the brain? Yeah, about 95, 99%. So the majority of right-handers will have language on the left side. What about left-handers? What's the likelihood of language being represented on the left side of the brain versus the right side? So it's about 70%. So even though you're left-handed, you still have language represented about 70% of the time on the left side. But the other part of it is that left-handers will have the potential to have language about 15% of the time represented on the right side of the brain, which is a reversal to what we see in right-handers, or the last 15% will have it represented bilaterally. So in some respects, if you have bilateral representation of language and you have a stroke, you might recover better because you have more tissue dedicated to the management of language. Last part is mood and personality, which I talked about, so I'll move past that. What Jennifer is going to talk about tonight is a very interesting disorder that happens after stroke. It's a specific or special type of inattention. So it falls under that rubric of attention, and as Heilman has reported here, it's a failure to report, respond, or orient to novel or meaningful stimuli presented to the side opposite of the stroke, so opposite of that lesion. It typically occurs on the left side. So left neglect is much, much more prevalent than the so-called right neglect, which to date, I must confess, I don't think I've actually seen a case of right neglect, but left neglect we see routinely, very common on our stroke unit. The incidence, there's a wide range, but it depends on which research study you read. But I think it's fair to say that about a third of those with stroke have some vestige of neglect. The unfortunate part is that a significant number of those patients remain with a persistent long-term neglect issue. Neglect is a condition that ultimately produces marked functional changes and functional challenges, which we'll talk about, or Jennifer will more than me. Somebody's probably sitting there thinking, why the left side? Why not the right side? And the reason that, as we understand it, is that the right hemisphere tends to have bilateral control of that attentional sphere. There's a part that will control this side and a part that will control this side as well. So the right hemisphere controls the contralateral side as well as the ipsilateral or same side. The left hemisphere doesn't have that opportunity. It just seems to control the contralateral side. So if you think about it, the right hemisphere, when you knock it out, all you've got left is the left controlling that. So your inattention to this side becomes very prominent. If you knock out the left hemisphere, you lose this one, but you have the right hemisphere still having the same side, so you still have that ability to attend to that side. So it's the very, very rare circumstance that you will have right neglect. Left neglect, about a third of stroke patients will have some aspect of neglect, and it doesn't mean they will all look the same, because some will have greater degrees of it or lesser degrees, but certainly a significant number of people with stroke, particularly right hemisphere stroke, will present with neglect. Talked about the functional implications. Significant, and it tends to be one of the best predictors of long-term functional impairment and a poor rehabilitation outcome. And that's something we see routinely, is individuals with a significant neglect have challenges that interfere with their ability to manage on a rehab unit, to be able to learn and take care of the tasks that they need to. So simply dressing, for instance, problems with being able to dress the left side of the body. When you think about going home, if you're not attending to the left side, how much of a challenge that would produce for you. So the functional limitations are significant, and they rank right up there with something we call poor insight or poor awareness. And so somebody has that kind of an issue also is a poor candidate for a good functional outcome. But neglect has routinely been demonstrated to be your best predictor of a poor outcome. So it has an adverse impact on general rehab, on your length of stay. So patients stay longer on occasion, but they may also stay a shorter period of time because it doesn't look like we're going to get anywhere. So it has an effect on both ends. And it has a significant effect on where you're going to go. And that's a huge issue, because I don't think there's a person in this room who, if you'd had a stroke, wouldn't say, I want to go home. You're not saying, I want to go to extended care. So it hugely affects the discharge destination. And if you think about being a caregiver and having to be there 24/7, that's not humanly possible. And so you're ultimately relegated to looking for alternate types of care if somebody is unable to show the kind of progress to be able to make it home. So the implications, as I mentioned, self-care. So the dressing, grooming, putting on your makeup, shaving, all of these things we take for granted don't happen. And so we see patients who shave one side of their face, who put makeup on one side, who wash one side of their body, who dress one side. And it's because we have left neglect, they're dressing and attending to the right side, they're not attending to the left side. They have trouble reading. And so you'll see a person with neglect try to read, and they're reading off the right side, but it's not making sense because we're not picking up the left side of the sentences. With eating, I'll show you this. So you can see this. And I had a patient who had enough insight, and he said that when he's having his supper, when he gets hungry, he just turns his plate for seconds. Very, very instructive and insightful. The issue of walking. Can you imagine walking and not attending to that side, and how that affects you on crosswalks and such? Driving becomes a non-issue for obvious reasons. Returning to work, a non-issue as well. So huge implications, and really speaks directly to the reason for why Jennifer is doing her research in this area. Here's another picture of what it looks like for someone with neglect, and you can see that the left side is not being attended to. But that's the real world that they see. One way to conceptualize neglect for all of you, because it's difficult to imagine how this can be, that the left side's still there, but we don't attend to it. So imagine yourself thinking about what's behind you. Until I tell you that, do you have any awareness of it? And I suspect you will say no, unless you have eyes in the back of your head. So in essence, that's a slightly primary way of thinking about neglect, is to realize that behind you there's a whole world going on, but you're unaware of it until you're directed to it. Why is Jennifer doing what she's doing? In part because she wants to finish her PhD and get out and work. But aside from that, the assessment part. The clinical guidelines say that we should be looking and assessing the condition of neglect, but it isn't done very well. And in part because there are subtypes of neglect that are not appreciated in the manner that they need to be. There's disagreement on how we assess neglect and what we're actually looking for. So there's only an agreement on the need to assess, but the rest of it falls off the table because we're not there yet. So that's an exemplary reason for why Jennifer is exploring this particular condition. And it's not like neglect just showed up. Neglect has been here for forever. It's ever since people have been able to have a stroke, neglect has been present. So we're into 2016, and if I look back to when my training started, which wasn't just yesterday, we're really not doing much better. And from a rehabilitative standpoint, we don't have much more to offer than we had back 20, 30 years ago. So I'm just going to show you this. From an assessment standpoint, one of the things we do is we ask patients to copy this. Now, it's not that bad. This is a copy. And I suspect everyone in here will do quite well. And then this is what we see with a patient with neglect. Now, you can see that only the right side is drawn here. But this isn't a very sensitive test to neglect. But I can obviously tell you that this person has neglect, but that's about all. So if you look at this and you come back to that, that's all I can tell you. Where Jennifer's going is to be able to discern some of these subtypes and then ultimately ways that we can hopefully intervene and improve a person's function. Because you can quite appreciate if that's all a person was able to do on a copy of that, so they're seeing this all the time, and that's their representation, you can imagine how that impacts on their day-to-day life. So just try and extrapolate from that into what you do in your day-to-day life, and if all you saw was that from that, that's a problem. So I'll just conclude by saying that where we really want to go with the research that's happening is to look at the rehabilitation treatment side. And assessment has to drive treatment. We don't treat without knowing what we're treating, but we actually do that. And that's unfortunate. We need to have that issue of assessment driving treatment. So to better understand this condition, fully appreciate its nuances, understand where we can intervene and maybe where we cannot. But we don't really know that at this point. So the clinical guidelines, again, will recommend treatment, but we don't know what kind of treatment per se. And as Jennifer will talk about, she'll elucidate on a couple types of neglect, which are markedly different, and so we shouldn't then think that the same kind of treatment is going to work with different subtypes. So as I said, the assessment development of rehabilitation strategies, I think it's a necessity and a priority. Research to date has demonstrated very limited progress, but I am confident that with Jennifer's research we'll get further ahead than we've been in many, many years. So I'm going to turn it over to Jennifer. So thank you.
Thank you very much, Dr. Miller. That was a great introduction to stroke and to my research in particular, which is in the area of neglect. What I'm going to do is talk to you about the subtypes of neglect that I've researched. I'm going to take you down into my rabbit hole of neglect that I've been in for the last few years, tell you about some of the cool things that we've found over the last few years in my research with my master's, and then what we're going to do moving that forward in order to make our lives better for our patients. As Dr. Miller kind of alluded to, neglect is a very poorly understood and very under-researched phenomenon. And this may be due in part to the fact that neglect represents a very complex, very heterogeneous sort of syndrome with different patients showing different sort of levels, different combinations of impairment. One way that we can kind of make sense of this is to actually break neglect down into its subtypes. And lots of different subtypes have been reported, things like motor neglect, visual neglect, tactile neglect, representational neglect. I won't go into all of them because there's many, but the take-home message is that it's very complex. Perhaps the most challenging aspect of categorizing neglect is differentiating between the subtypes of allocentric and egocentric neglect. And the reason for this is that the two subtypes are neither sort of readily distinguishable between each other if you look at everyday patient behavior, nor are they vastly different in their presentations, but they actually do have very distinct and very meaningful impacts on a patient's perceptual world. So let's talk about what each of these means. So egocentric neglect, or person-centered neglect, refers to a failure to perceive stimuli that are located on the contralesional side of the brain injury, and this is relative to the person's body midline. So if I have neglect, I'm looking out at this room, relative to my body midline, I'm probably missing out on a good portion of this side of the room altogether. So that's kind of the typical neglect that we think of when we talk about it. Now, allocentric neglect, on the other hand, or object-centered neglect, is a little bit different. It refers to deficits in the perception of the contralesional side of individual objects. So this could be different objects in a complex scene, individual words on a page, for example. And this is actually regardless of their position relative to the body. So again, for example, if I'm looking out at this scene, I'm actually perceiving the entire scene, but I'm missing out on half of the objects within that scene. So I may only be seeing half of you sitting there. I see half of the accent sign at the top there. Over here, I'm seeing, half of this wall piece over here. You're getting the whole scene, but you're missing out on the left side of individual objects within that scene. So one way that I can kind of show this to you in a little bit clearer detail is with some pictures. So if the person's asked to make a copy of the image on the top, you can see that the egocentric neglect patient is kind of globally just missing out on the left side of that picture. So they've missed out really on the entire left side of that image. Now with the allocentric neglect patient, on the other hand, they've got the whole scene, but they're missing out on half of each piece within that scene. So we've got half of the tree, half of the fence, half of the house, and so on. We looked at this and we thought, wow, like these things are really different from each other. These are really, really different presentations. And yet still most centers, most researchers are lumping these patients together just in the category of having neglect in general. So it kind of made sense to us that people with either of these types of neglect might actually behave differently when it comes to their real-world behaviors, and they might have different functional outcomes. And so we actually set out to test this. So the first thing we needed to do was find a better test of neglect, because as Dr. Miller mentioned, the tests that we have really aren't that great. So we found a really cool tool. It's a really simple task. It's called the apples test, and this is what it looks like here on the screen. So in the apples test, we get a sheet of apples. Some of the apples are complete, and then some of the apples have gaps on either the left or the right-hand side. What we ask our patients to do is cross out all of the whole apples and leave all of the apples with gaps alone. So knowing what we know about egocentric neglect, we would expect that these patients would mainly make their marks on the right side of the page, and then they would leave most of those stimuli on the left side of the page completely blank and not touch them at all. And so on the other hand, if we have an allocentric neglect patient, they're probably making their marks across the entire page, but they're going to incorrectly mark some of the apples with a gap on the left as being whole because they're only perceiving that whole side. So they're just assuming that that apple is actually a complete apple, so they're going to make those kinds of mistakes. And so with this really simple test, we're able to calculate these things called asymmetry scores, and then that's going to tell us whether someone has egocentric neglect, allocentric neglect, or both neglect subtypes simultaneously. So a very simple tool, but also really cool. So the apples test is definitely pretty neat on its own, very innovative, but we wanted to take it one step further and really dig into these sort of attentional patterns that we're seeing with our neglect patients and with their eye movements that they're actually exhibiting while they're doing these tasks. So we got really fancy and we found ourselves an eye tracker. So with eye tracking systems, what we get is a continuous measure of attention by sampling the velocity of eye movements, the direction. We've got gaze fixation, fixation duration, basically a ton of data that's coming out about where your eyes are looking, and then we can make inferences about what you're paying attention to. If we consider neglect to be a bias in attention towards one side of space, so you're more likely to attend to the right than you are to the left, then it makes sense that eye movements might be correspondingly affected. And we know this is probably true because you can't actually move your eyes to any location without also shifting your attention in that direction. And since the attentional deficits that we see with our allocentric neglect patients and our egocentric neglect patients are very different, we thought that we might see differences in the patterns of eye movements between these two groups and that our eye tracker would then be able to pick up on those differences. Okay, so what we did was we had our neglect patients come in. They completed a computerized version of the apples test, and while they were doing that, we tracked their eye movements. So this allowed us to see in real time where our patients were looking on the computer screen. We also, while we had them there, administered a very large battery of cognitive tasks, and then also a functional assessment to let us know how our patients were doing in the real world. Okay, so what did we actually figure out? So first of all, it turns out that eye tracking is actually a much more sensitive way of detecting neglect among stroke patients. If we just use the data from the apples test, that showed us that 56% of our sample didn't have neglect at all, and only 44% of our sample did. When we used on the same participants the data from our eye tracker, we found that 75% of our sample was actually showing up as neglectful, whereas 25% was not. So a pretty big difference there in the detection rates with the eye tracker versus with the pencil and paper measure. So it seems like the eye tracker is better able to pick up on some of those very subtle sort of attentional patterns that we see in neglect patients that other measures of neglect, more crude sort of behavioral measures, just can't pick up on. Now, what did the eye tracker tell us about the different subtypes of neglect? Because that's what I was really interested in looking at. Well, it turns out that people with different neglect subtypes did in fact have different attentional patterns that were picked up by the movements of their eyes with our eye tracker. So what you're looking at here are examples of heat maps of some of our patients. Essentially what you're looking at, this is a heat map. It's the redder or the hotter the area is, that means the longer the amount of time they're spending looking at it. So in a patient with no neglect, we're seeing that this is pretty similar across both sides of the page. They're attending pretty equally across the entire page. Same thing with our allocentric neglect patients, and this makes sense because they're missing out on the left side of individual objects, which wouldn't be picked up in this sort of crude, larger scale that you can see there. But now with the egocentric neglect patients, we are seeing quite a difference. So they're spending a lot less time as we get farther over to the left there, a lot less time. And when patients had both neglect subtypes, that difference becomes even more exaggerated. Now, the really neat thing about this is if we look, for example, at the egocentric neglect data, what we see is that there doesn't seem to be some sort of invisible barrier at midline beyond which their gaze won't stray. So you can see there's a couple of little blue spots there. They are actually kind of making it over there. The point is that they're actually just not staying there for very long. So it could be the fact that neglect patients can actually get over to the left side of space, but they're just less likely to spend time there, less likely to stay there, and that's where their deficits arise. So that's kind of an interesting finding, but why does it actually matter in the long run? So a few moments ago, Dr. Miller mentioned that neglect is associated with many different sort of functional impairments and consequences. And I mentioned that those consequences might be different based on the subtype of neglect that a person actually has. And so that's what we looked at next, and what we found was quite interesting. On this graph, we've got the patient's functional score here on the y-axis, and the lower the score is, the better you're doing functionally. So you want to be lower on that scale. And then on the bottom, we've got the neglect subtype. So we can see here that the patients that have no neglect have the best functional outcomes overall. That's not surprising to us. Next, we have the egocentric neglect patients. So they're doing worse than patients with no neglect. Next comes the allocentric neglect patients who are doing even slightly worse. And then finally are the patients with both types of neglect who are doing significantly worse than any of the other three groups. What does this all mean for the real world? Why is it important? There are a bunch of fancy graphs and fancy things to look at, but it's looking like eye tracking systems are going to be a really promising tool for us to use in the assessment of neglect moving forward from here. It's really important that we're differentiating between these neglect subtypes, and it seems like an eye tracker is really the best way for us to do that. Second, we're seeing that it might actually matter what subtype of neglect a person has, so lumping them all together into one group just called neglect isn't necessarily helpful if some of those patients are going to do better and some of those patients are going to do worse. So that provides us with a really compelling rationale for actually differentiating between these neglect subtypes as we're doing our assessments, especially in primary care settings where we really want to maximize our prediction of how patients are going to do and really tailor treatment towards their specific needs. And then that brings us to the final point, which is treatment. And so seeing what we saw in our research about the patterns of neglect patients' eye movements, can we now segue that into sort of better treatments for these patients as we move forward and think about making their lives better? And that's exactly what we hope to do next. So how can we actually apply what we've learned into the treatment of these patients? We know that our patients now can actually get over to the neglected side. So that indicates to us that there's some component of early, more automatic processing that's actually relatively preserved after their stroke. So is there a way now that we can capitalize on that? Can we retrain that sort of later, more controlled attention in order to get them to stay on that neglected side, to actually pay attention there, stay over there, and compensate for the loss of that perceptual world? And can we use our eye tracker as a treatment tool to actually help us do this? And I hope the answer is yes. We plan to develop a computerized treatment paradigm with the eye tracking system that's going to allow us to really see and quantify patient improvement in real time, which is really exciting. For example, can we program a game into the eye tracking system that won't allow you to advance onto the next sort of section of the game until you spend a sufficient amount of time looking at the left side? Could we use digital cues on the screen to help people sort of draw their attention over to that neglected side and then see what happens? And can we use videos, actual everyday scenes of real life rather than just hospital rooms to sort of make this treatment more valid and more realistic for our patients for their ultimate goals, which are to get home and to live an independent life and to get back to everyday living. So that's what we plan to do next. Those are the goals for us. That's all I have for you in terms of my own research. I hope you've enjoyed that little sort of mini tour of my world of neglect. And with that, that's all we have for you today. So thank you so much for coming.